Hello, and thank you for joining me today. I'm Dr. Jamila Porter. I'm Senior Advisor for Program and Strategy at the Beaumont Foudation. Today, I'll discuss the root causes of health and quality of life outcomes, including those related to injuries and violence. This is a foundational framework for understanding how many different systems and structures drive the health and quality of life outcomes that we see individually, across communities, and throughout our nation. Our systems and structures that are interconnected and that directly impact how long and how well we live. And we'll walk through this framework piece by piece. But before we get started, I want to first acknowledge the many organizations and scholars whose work has directly influenced the structure and elements of this framework. This framework was informed by innovative work that has been conducted by organizations like Change Lab Solutions, the Safe States Alliance, the Beaumont Foudation, and the Big Cities Health Coalition. The framework was also directly informed by insightful research and scholarship conducted by Dr. Kamara Jones and Professor Rakaya Yerby. I highly recommend reading these two articles in particular, as they will add further context and richness to your understanding of the concepts that we'll discuss today. Health is not just physical health or individual health. Health is multidimensional and communal. Health is connected to and influenced by every aspect of our lives. Health is connected to our employment and income, to our access to education, and our homes and neighborhoods. Health is linked to our ability to travel safely from one place to another, our ability to vote and inform decisions within our communities, and the ways that we engage and connect with people in our lives. But underneath these aspects of health, there are root causes that shape the range of possibilities for our health and quality of life. We call these the social determinants of equity. They are systems of power that govern the distribution of resources and populations through decision-making structures, policies, practices, norms, and values. They often operate as social determinants of inequity by differentially distributing resources and populations. They can include, but are not limited to, structural racism, sexism, ageism, nativism, ableism, and poverty. We see the impacts of the social determinants of equity play out every day through intersectionality. Intersectionality is a term that was coined by Kimberly Crenshaw, a civil rights activist, professor, and legal scholar. It is used to describe intersections of marginalized identities, such as being a person of color, being disabled, being low income, or being an older adult. When you have multiple marginalized identities, they intersect and compound the impacts of multiple forms of oppression. Individual people experience these multiple forms of oppression, but because we are dealing with systems of oppression that are patterned, well-practiced, and create similar adverse outcomes across large numbers of people, we can also see how intersectionality and the compounded impacts of multiple forms of oppression affect entire populations of people. An injury-specific example like pedestrian safety can help illustrate this. In the hierarchy of our nation's road transportation system, the pedestrian is on the lowest rung. Being a pedestrian is a marginalized identity even in of itself. But then you intersect that identity with being Black, Native American, or Indigenous, all of whom are more likely to be killed on our nation's roads. And then you intersect that identity with being low income, as pedestrians who are low income are struck and killed on our roads at much higher rates. And then intersect that identity with being an older adult. Pedestrians who are older adults are disproportionately more likely to be killed on roads throughout the United States. At this point, the compounded impacts of intersectionality become clear. A pedestrian that is Black, Native American, or Indigenous, who is also low income and an older adult, seems to have no real chance of surviving on our roads. And when we look across all systems and structures within our society, these root causes, the social determinants of equity, ultimately fuel several fundamental drivers of health inequity. They include structural discrimination. With structural discrimination, these are laws and public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways that perpetuate group inequity. Structural discrimination is generally based on categories of identification, such as race, gender, sexual orientation, social class, and immigration status. Even policies designed to protect groups, if implemented unjustly in a systemic fashion, can perpetuate structural discrimination. Another is income inequality and poverty. As systems of power, the social determinants of equity play a central role in both concentrating wealth among the wealthy and making it difficult for those who are impoverished to escape poverty. One example of income inequality is related to community disinvestment. This is where communities are allocated fewer resources and denied critically needed investments. This disinvestment can result in chronic community-wide neglect, disenfranchisement, abandonment, and even demolition. When it comes to pedestrian safety, for example, marginalized communities have often been refused much needed funding for road safety and for infrastructure improvements for decades, which would have protected the lives of many pedestrians in these communities. Disparities in opportunity refer to inequitable access to quality education and economic opportunities, which create fundamental barriers to health and widen gaps in wealth and health between marginalized communities and wealthier communities. Disparities in political power refer to how communities with insufficient political power find it difficult to make their problems and needs visible to government and institutional decision makers. This disparity is exacerbated by voting laws that create barriers to democratic participation and civic engagement. Those with greater political representation and input ultimately have the power to influence legal, political, and budgetary decisions. And finally, we have governance that limits meaningful participation. Governance is the process of aligning stakeholders and getting to agreement. Governance structures determine how power is distributed and exercised in decision-making in ways that shape places as well as access to resources and opportunities. However, in communities where civic participation is restricted or suppressed, community issues become easy to ignore, and the power of these communities is perpetually diminished. As we move up the framework, we get to the social determinants of health. The social determinants of health are the conditions and context in which people are born, live, learn, work, play, and age. The social determinants of health directly affect a wide range of health, functioning, and quality of life outcomes. These conditions can be social, economic, and physical, and they include policies, systems, and environments. They include economic stability, which includes employers and employment-based systems, as well as public assistance programs, banks, and other systems that impact income and economic well-being. Education includes early childhood education systems, K-12 school systems, colleges and universities, school boards, parent-teacher associations, and other related systems. Neighborhoods, housing, and the built environment refer to private and public housing systems, city planning and zoning, developers, road engineering, parks, and other systems that influence physical spaces. Public health and healthcare delivery systems include public health departments, as well as other organizations that are distinct from but connected to public health, such as hospital and clinical care systems, mental health agencies, pharmacies, and health insurance systems. Resources, goods, and services include things like public transit systems, food systems, and utility providers. Social and community contexts include systems that directly impact social and community structures, including election and voting systems, civic engagement processes, offices of elected officials, and the criminal legal system. And toward the top of the framework, we have health and quality of life outcomes. These are the end game, the culmination of what we experience in terms of how well and how long we live. They include physical and mental health, which includes being free of injury or illness, as well as positively coping with the normal stresses of life. Gainful employment and livable wages include the extent to which people have jobs that provide living wages that allow them to meet their household's needs and provide sufficiently for their families. Safe and stable homes and neighborhoods include having homes that are free from health hazards and are built in safe and walkable communities. Educational achievement can include the quality of education and the rates at which high school and college students successfully graduate. Access to affordable and high quality goods and services includes access to a variety of goods and services such as public transit and grocery stores, as well as the extent to which these goods and services are affordable, useful, and desirable. Community connectedness, engagement, and participation include the ability to connect with one's community members, drive agendas, and inform decisions. These can include experiences like the ability to vote in elections, engage in civic activities, and attend public meetings. When we look at the framework at this point, we can see a clear gap. Something mediates the relationship between the social determinants of equity and the social determinants of health in ways that ultimately drive health and quality of life outcomes. We call these structural tools. A variety of structural tools exist that governments, ranging from municipalities to federal agencies, can deploy to broadly address the social determinants of equity, the social determinants of health, and health and quality of life outcomes. They include law and public policy. A law refers specifically to the codification and institutionalization of a public policy by a government in the form of an ordinance, statute, or regulation. All laws are policies, but not all policies are laws. An example of that is organizational policy. An organizational policy is a structural tool that refers to a written statement of a public agency's or organization's position, decision, or course of action. With practice, a practice is an informal professional procedure that is implemented customarily or habitually, but is not considered a formal policy. A budget is a proposed plan for managing public funds, setting levels of spending and financing. A budget can serve as a policy statement and a starting point for fiscal decisions and budgetary actions. The budget process is the primary means by which governments select among competing demands for the allocation of funds. Collaborative governance is a governing arrangement in which public agencies directly engage non-governmental stakeholders, such as individuals and residents or community organizations, in collective decision-making processes that are formal, consensus-oriented, and deliberative. The goal of a collaborative governance process is to make or implement public policy, as well as manage public programs and assets. A participatory budgeting process is an example of collaborative governance, as it involves formally engaging community members and community organizations in decision-making processes related to spending part of a public budget. And then we have data and research. Research includes creating new knowledge and using existing knowledge in new and creative ways to generate new concepts, methodologies, and understandings. The analysis, synthesis, and interpretation of research data can inform strategic decisions by revealing the root causes of persistent issues, diagnosing breakdowns in systems, highlighting obstacles, and predicting future phenomena. The structural tools mediate the relationship between the social determinants of equity, the fundamental drivers of health inequity, and the social determinants of health. Structural tools directly influence our access to the social determinants of health, which then drive specific health and quality of life outcomes. At the same time, structural tools both shape and are shaped by the social determinants of equity, which is depicted here in the framework by a double-sided arrow. This double-sided relationship is important. The social determinants of equity influence how and to what degree the structural tools are created and utilized. Like any tool that is influenced by systems of power, structural tools are not neutral. They can be used to protect those who have been historically marginalized in ways that promote justice, or they can be used to reinforce structural inequity and oppression. For instance, for decades, Jim Crow laws and redlining were forms of discrimination that were codified in law, policy, and practice in ways that intentionally benefited white people and intentionally harmed Black people and other people of color. Laws like the Civil Rights Act of 1964, the Voting Rights Act of 1965, and the Fair Housing Act of 1968 were adopted in an effort to prohibit these practices. However, even these federal laws fell short in many ways, given that we still cope with systemic inequities in civil rights, voting, and housing to this day. These shortcomings reveal that an intentional and sustained focus on equity, egalitarianism, and justice are critical for structural tools to realize their power and potential to affect positive and systemic change. So structural tools are still, though, the primary levers of change that we have at our disposal to transform the social determinants of equity, to provide equitable and just access to the social determinants of health, and to ultimately create positive health and quality of life outcomes for every community. Health and quality of life outcomes are measures of how equitably and how justly the structural tools are operating and being utilized. As public health professionals and as injury and violence prevention practitioners, we must wield structural tools in ways that are equitable and just. But this also means that we need to understand the critical difference between equity, equality, and justice. We know and acknowledge that inequality in any form is completely unacceptable. When it comes to equality, which is providing an even distribution of resources, we know that equality won't make a dent in any of our problems either, given that systems, laws, policies, practices, and budget allocations have been distorted over decades to actively advantage some and actively disadvantage others. However, that's why we have to start with equity. Equity acknowledges that everyone doesn't start from the same place in life. People and communities have been differentially impacted by a variety of circumstances, structures, decisions, and historical contexts that have intentionally advantaged some and intentionally and unjustly disadvantaged others. However, Equity requires that we do and live up to three things. First, we must value all people and individuals equally. This means ensuring that every community, particularly those who have been ignored and harmed, are uplifted, engaged, valued, and allowed to drive decisions and agendas related to our work. Second, we must recognize and rectify historic injustices. This requires acknowledging our full and shared history within our organizations, our communities, and our nation. It also requires understanding how past policies, practices, and decisions continue to have present-day impacts. We can only make informed decisions for the future and for the present by fully recognizing, wrestling with, and rectifying the injustices of the past. And third, we must provide resources according to need. This means that those who have been disadvantaged require a differential allocation of resources and opportunities. Those who have been harmed most must be given disproportionately more in an effort to try and set things right. But we must also acknowledge that equity can get us to fewer injuries and injury-related deaths, but we can't stop there. If we're really interested in transformation and creating a nation free from injuries and violence, then we have to go further and we have to work toward justice. Justice embraces the three requirements for equity, but it goes further. It requires repairing and transforming circumstances, structures, contexts, and systems themselves, symbolized here by the tree, so that they are equitable by default. If we can look at issues of injuries and violence from a big picture perspective focused on equity and justice, we'll find that issues like traffic deaths, opioid overdoses, suicide, and community violence are not separate and distinct, but in fact, they are deeply intertwined and interconnected. By acknowledging these connections and addressing the root causes at the heart of these connections, we can make sustainable progress across a host of injury and violence-related issues simultaneously. Any fundamental shift to make a system more equitable and more just will prove to be a significant political, social, and professional challenge. As injury and violence prevention professionals, making this fundamental shift is the immense challenge that lies before us. No one is saying that any of this will be straightforward or easy. Any fundamental shift in how we've always done things will be difficult. It will take committed partners and it will take tremendous work, but we can and we must. It is our moral charge and our professional responsibility. And we must do this if we truly hope to create a healthier, more equitable, and more just nation that fulfills our vision, a nation free of injuries and violence. Thank you.